when we see it in the tissue-wise, there's the orbicular with retaining ligaments down here. It's a true ligament. It comes out from the periosteal layer and inserts to the dermal layer. So this is one thing that gets age too. The collagen proportion of type 3 and 1, it changes as aging. So they get, some people say they don't get laxity, but they do actually. So the veins and arteries. So arteries, they are typical arterial running of facial artery is type 2. Okay, type 2 is it merges with the infraorbital artery and runs as an angular artery to the canthal region. So this is like 50% of our population that has. So this is like a facial, like average facial distance from the prominent anatomical landmark. So this is like a general pattern of facial artery. It does not go right next to the ulnar region. It's more way far laterally running and runs up to nasal area. So when it comes to angular artery, it runs in the right
CT scan images in November 2020. So we can see a increased soft tissue density and along with the increased skin thickness in her mid-facial area. And after multiple treatments, she was followed up with MRI in July 2023. So this is axial T1 weighted image without contrast view. So we can see multiple ISO signal nodal lesions. When I say ISO means is much more like the same density with the muscle, or we can say the soft tissue density in the same area, the similar area as the CT scan showed. And this is the axial T1 weighted fat suppressed patient with contrast view. Lesions have mild contrast enhancement, which means that there is increased blood supply or vascularity in these lesions. And under the axial T2 weighted fat suppression with contrast view, some high intensities are noted. So indicating there are more fluid existence and hence a more cystic component.
The useful eyelid litchi junction is shorter, and the edge of the eyelid litchi junction will be longer. Because the mid-face where the orbital bone will be absorption over edge. Before we always inject HA by the ND curl teach by the Dr. DeMille. They use the TT2, TT3 to remove to support the lateral litchi junction. And we also know fashion engine structure and foreign deficient is also important, like the vertical descent. The defect component, foreign loss, is the important etiology of the facial engine. And the defect component is like the lateral and medial SUV, subocularis ocular fat, and the deep medial cheek fat component is the deep fat. This is the SUV. The area is like the middle and to lateral. So the deep fat injection, especially for injecting to the SUV, can give a structural support for where mid-face and where
potential complications. So, for example, if we want to remove the suture material, I'm not sure the injection material for the upper orbit, Usually we make an incision, subbrow incision, and dissect into the submuscular area, subcu area to remove the injection material. Or we can also go through the blepharoplastic incision, which is of course more difficult. So if it goes through the blepharoplastic incision, there is usually higher risk of causing multi-fold, multi-crease, because the surgery can cause some adhesion inside the orbit. For the lower eyelid, if you try to remove the material, you can either go through the conjunctiva or make an external incision to approach the product. Like I said, there is higher risk of causing complication. Most common is eyelid atropion, right? Because the biostimulator usually can cause some kind of scarring process in the lower eyelid. So you try to remove it surgically, you will go through that area, and surgical itself can also cause scarring process. So there is higher risk of causing
strength. The tissue, the fibrous tissue is different. Deep pad tissue is the oblique and loose, but the superficial area is generally straight and tight, more tight. So we all know that subcutaneous cannula advance is more difficult than deep pad area advance. It is evident. So tensile strength of the tissue, vessel and nerve are stronger than the pad. And so required force for penetration, vessel nerve also, the requirement force is larger than the pad. So we must use this pad. When we use the cannula, we must advance the cannula soft and slow and always feel the sensation. And when patient tell the pain arises from the generally vessels and the nerves and some fibrous tissue. So we always focus on the pain and the right hand sensation. So smooth and slow advance of cannula and pad penetration requires much less power rather than the vessel nerve penetration. So we must focus on the training of our right hand and left hand sensation. So, but the exception is the weak vessel. Generally, the terminal area of the...
your filler is going to age with an aging patient. And that's the thing that we see with fillers is the delayed swelling. In a systematic review recently, 40% of patients see delayed swelling, approximately 14 months to 24 months after under-eye filler. And this is, for me in the West, this is a huge problem. I see at least 5 patients every day with under-eye festoons and malar edema. And, so the second thing that I've incorporated in my practice is ultrasonography. I absolutely cannot do without it. And the techniques I use for dissolving filler, because, although, yes, filler can be dissolved, it can be very traumatic to dissolve for not only the practitioner, but also the patient, because they've forgotten the underlying hills and valleys, the convexities, the concavities, and the orbital fat prolapse that's occurring, and so these are not easy cases. I know we all share this pain. And so as Stephanie said, less is more, not injecting patients who have a predisposition to malar edema, checking and ensuring that the tissue